Hello, I'm Nora Hanna, Chief Engagement Officer at Sun Health, and I'd like to welcome you to this episode of Coffee Connections. We created this series to help you stay connected to the latest developments in healthcare and wellness by hearing directly from experts in our community. The Sun Health Foundation is committed to ensuring that this region has access to the most recent medical and technological advancements, and that we attract the brightest and best practitioners for care. To that end, we are the exclusive philanthropic partner to Banner Boswell and Banner Del E. Webb Medical Centers. Our mission is to empower others to live longer, healthier, and more purposeful lives. So we're excited to be able to offer you this unique access to these valuable expert resources. Thank you for joining us and enjoy the presentation.
Well, thank you for that wonderful introduction. Good morning, everyone. My name is Oliver Coe. I am a urologist at Academic Urology and Urogynecology of Arizona. I started my official real grown-up job last year, so I'm in my 1-year anniversary now. But it's been a long road getting here, and in honor of September, which is Prostate Cancer Month, the focus of the talk today is going to be about prostate cancer, particularly looking at early detection and modern treatment strategies. This is meant to be an interactive presentation, so by all means, if there's any questions, comments, please feel free to chime in and we'll take a pause to address that. But there will be a dedicated question and answer session at the very end as well. So without further ado, Pam did a great job doing some of that introduction, but yes, I am a Phoenix native. I went to the University of Arizona, so go Cats, despite our bad loss against Kansas State. We will regroup and bear down. My journey after that led me to Case Western Reserve University for medical school in Cleveland, Ohio, one of the oldest medical schools in the country. And after that, I spent a 6-year urology training residency program at Northwestern University in Chicago. And finally, I wrapped up with a year in doing a fellowship training in advanced robotic surgery and minimally invasive oncology at the University of Southern California in LA. But despite that, I'm not a Trojans fan, so don't worry. So just a brief plug about our practice. So we're a pretty big group. We've got a pretty large footprint here in the Metro Phoenix area. We cover all the way from Scottsdale out to Goodyear and soon to be Buckeye. We have 9 urologists in our practice, as well as 4 urogynecologists located across 12 different locations. My particular interest, as Pam highlighted earlier, involves many things, including urologic cancers, as well as kidney stones, and avoiding problems in prostate issues. So before we dive in, the objectives for the talk today are we are going to talk about what prostate cancer is. Some of you may have a very good idea, and others may have been just a term that you have heard but not really sure what that really means. So we'll do a general overview as to what that is. Then we'll move on to who should be checked for prostate cancer and how do we check for prostate cancer. And then we will look at what are some of the common treatments and management strategies we have in place for dealing with prostate cancer. So the prostate is a male reproductive organ. It's about the size of a walnut, but unfortunately as men age, that often becomes much larger than that. It sits in the pelvis, located just underneath the bladder, and its main function is really for male reproductive health. So it helps with the excretion of semen and helps provide nutrition for the sperm during the reproductive years. And some think that it is also involved with generating that sensation of pleasure with male orgasm. So what is prostate cancer? Well, cancer in general is really just a rapid and unregulated growth of the normal tissue cells. And often in that process, these cells lose their normal functional ability and become sort of useless and just consume energy. So a cancer of the prostate typically involves the cells that create the lining or the ducts of the prostate for that secretion function that I mentioned earlier. And we call that an adenocarcinoma, which is a fancy way of saying it's a cancer of the duct cells of the prostate. And how we think about how to grade it, we do it in many different ways, but probably the most the best way to understand is we look at the pattern of those cells and how aggressive it looks. And we use something called the Gleason score, which some of you may have heard of, or something called the grade group to classify the aggressiveness. So, there's a different scale criteria. If you use the score, it goes from 6 to 10. If you use the grade group, it goes from 1 to 5. I'm not going to delve too much into that, but you can see here on the picture, if you look at all the way on the screen, left there, you can see that's a Gleason 1 or a grade group, or a Gleason 6 or a grade group 1, so cancer. So not very aggressive. You can see the cells are very small, they're very uniform, they all in all look about the same. And as you move towards the right of the screen, you can see that these cells, they get larger, they become more and more abnormal, and they lose their typical function. And that signifies a more and more aggressive cancer as it begins to develop. Any questions so far? If we look at prostate cancer and think about prostate cancer in a population, from a population standpoint, well, in the United States, it's the #1 most diagnosed cancer in men, and that's why it's a very important topic to talk about and understand. It is the #2 cause of death from cancer in men in the United States. And 1 in 8 men in their lifetimes will be diagnosed with prostate cancer. So looking at 2024, you can see that the estimated new cases for prostate cancer was about 300,000, just below breast, which is the most common type of cancer here in the United States. Thankfully, the survival from prostate cancer is quite good. So looking at data from 2014 and 2020, and this is all public government data that anyone can access, the overall 5-year survival rate is upwards of 98%. If you look at that graph there on the bottom, I want to highlight your attention to these green, these green inverted triangles. And this graph doesn't do it much justice, but what you can see is that from 1992 to 2022, we have reduced the rates of death from around 50 cases per 100,000 people to close to 25. So almost cut that in half. And much of that can be attributed to better detection, screening the appropriate patients, and better treatments that we have for prostate cancer. So who should be screened or checked for prostate cancer? Well, different professional bodies will recommend different guidelines, but in general, the way I think about it is, men around 45 to 50 with no risk factors should begin the process of being screened for prostate cancer. Men at age 40 with risk factors, and this is becoming increasingly evident, particularly in men of African ancestry, which is a big risk factor, because we know that those patients tend to harbor more lethal and more aggressive cancer, so we can't apply general screening guidelines for the regular population for that specific cohort of patients. Also, patients that carry known mutations, particularly a BRCA2 mutation, and in many of these patients, they have a strong family history of breast and ovarian cancer. Anyone that has a first-degree relative with prostate cancer, first degree meaning your father, your brother, or perhaps your son, those patients should be screened. Or a patient that has multiple relatives that are not first-degree people that have prostate cancer. Screening should happen on an interval of anywhere from 1 to 2, some people say 3 years, just depending on how old you are and your risk factors. In general, the younger you are, you probably can go a little longer of an interval before getting checked again. And in general, the guidelines will say around 70 to 75, they don't recommend routine screening anymore. Now, that is a very personalized decision, and that applies to the general population. But I have seen 90-year-olds that look like 60-year-olds, and in those patients, it makes absolute sense to still get their prostate checked to make sure that there's no cancers. And I've seen 50-year-olds that look like 100-year-olds, and in those patients, it may not make so much sense to continue to check for prostate cancer because of the inherent slow growing process of this disease. So now that we talked about who should get checked for prostate cancer, well, how do we check for prostate cancer? We do that with 2 simple tests. Most commonly, it's done with something called a PSA. It's a blood test, and a rectal exam. And there's more and more evidence now to suggest that maybe the rectal exam is not necessary anymore. And that's a point of debate, but certainly that PSA blood test is something that should be done for the screening of prostate cancer. So the PSA is it's called the prostate-specific antigen, and it's a marker that's made by cancer cells in the prostate in a much higher ratio compared to normal cells in the prostate. And I'll talk about that in a little bit more. And then on a rectal exam, what the doctor is feeling for is your size of your prostate, but also if they feel that any firmness or any nodules that might suggest that there's a tumor that's starting to grow on the prostate. And rarely, this is a very important point, rarely do we actually diagnose prostate cancer in men that have urinary symptoms. So getting up a lot at night, frequency, weak stream, that really is usually attributable to an enlarged prostate, which size and cancer of the prostate have no real correlation. So that's a very important point to remember. And if there is an abnormality in that blood test or on the rectal exam, then generally, eventually a biopsy will need to be done to confirm to see if there's any cancer or not, which I'll talk about here in the next few upcoming slides. So as I mentioned earlier, the PSA, or the prostate-specific antigen, is a blood marker that's secreted by cancer cells. To date, it remains the best biomarker or blood test we have to predict for cancers. So it's really quite amazing. Its function is really to keep the sperm from coagulating, and it was first described in animals in 1972. And one of my mentors and one of the godfathers in our world, Dr. Catalona, first described using this blood test as a way to check for prostate cancer in 1991. And that was published in the New England Journal. It remains one of the most hallmark studies in our world and really revolutionized our field, because prior to that, patients got diagnosed with prostate cancer when it was already incurable and very, very advanced. And the important point to keep in mind is that the PSA number also changes with age. In general, if you've ever had a PSA test done before, you'll see that the result will give you a cutoff of 4. So anything above 4 is considered abnormal. However, if you are a younger patient, PSA of 4 might actually be too high. So the median PSA in someone that is across the population and anyone between their 40s and 50s is actually only around 0.7. So if you have a PSA greater than 2 or 2.5, you're considered elevated. And as you age in the 60s, that median PSA rises to 1 and 1.5. Now these are normal, healthy patients without prostate cancer. And so that number, it's important to keep in mind for younger patients that when they see that number, 4 is not necessarily the cutoff, but certainly above 4, you should be concerned, or you should be thinking about getting a further workup with your doctor. Any questions so far?
How do you decide on whether you should have surgery?
So the audience's question was, how do you decide if you should have surgery? So that's a great question. We will get to that here in the next coming slides. So there are unfortunately other reasons, or fortunately, other reasons for the PSA blood test to be high. So we talked about cancer as being one of those causes. Other things that can cause that blood test to be high include having an enlarged prostate, or inflammation or infection of the prostate, which can drive up those cells that release that marker. Irritation or trauma on the prostate, such as bike riding, a recent rectal exam, or recent ejaculation, can also drive up that number. So the question is how do we know if someone's PSA, when it's high, is related to a cancerous versus a non-cancerous cause? Well, fortunately, technology has come a long way, and now we are incorporating using MRI technology to better look at the prostate to see if there's any areas of concern. So has anyone here ever had an MRI? Just by a show of hands? So quite a few of you, right? And I'm sure it's not a terribly fun experience, but basically the general principle behind it is you go into a giant magnet, and the magnet induces spin in your body's atoms. And as the atoms spin and they relax, it releases a signal, and the machine is able to pick that up and create a picture out of it. And you can see here, I've included some pictures of a prostate MRI. Basically, it lets us see how does your prostate look, how big is it, and if there's any concerning spots in your prostate or not, which might be concerning for a prostate tumor that is growing that we can't pick up on a finger exam. Reasons you shouldn't get an MRI are extreme claustrophobia. If you have any metallic hardware in your body that is not MRI compatible, now there's more and more implants now that are MRI compatible, so it's important to look at that. Or if you have a severe allergy to the type of contrast that they would give you for an MRI, those would be reasons not to do that. Like I said, it provides high resolution pictures and lets us know if there's any suspicious areas. And we have a grading system we use to tell us if there is a suspicious area, how suspicious is it? And we really only care about the areas that we score a 3 or higher. But if you score one of those, then you probably should talk to your doctor about getting a possible biopsy. And those pictures there, they points out a suspicious nodule across the different phases of the MRI. So eventually, the only way to really know if someone has a prostate cancer or not is to proceed with a biopsy or a sampling of the prostate. This is typically done in either two ways. It can either be done transrectally or transperineally, which is the area of the skin between the scrotum and the rectum. Typically, it's a 5 to 10 minute procedure. It's done in the office. We usually give local anesthesia, like when you go to the dentist and we numb up things, and then we take samples of the prostate. If you have a spot on your MRI, we often can use something called fusion technology, where we're able to line up that suspicious spot to our real-time ultrasound, which guides our biopsy to be able to better hit that area, versus before we were just blindly sort of sampling the prostate. And the downsides of the biopsy are, the biggest downside is there's a chance of a severe infection. There's about a 2% chance of that. And if you have a large prostate, there's a chance that you temporarily might not be able to urinate because there's some inflammation. And it can lead to bleeding, which is expected, but sometimes it can be quite heavy where it might require a catheter or a hospitalization or something like that. Now, say we found prostate cancer. Well, and say we found aggressive prostate cancer. What happens in a patient that has aggressive prostate cancer if we did nothing and just left it alone? Well, if that were the case, the traditional way that it's been described is what we call the cascade effect. And typically what happens is the tumor will continue to grow into the prostate to where it gets big enough or gains enough mutations where it has the ability to break out. Once it breaks out of the prostate, it has the ability to spread to the lymph nodes, typically in the pelvis. Lymph nodes are areas where your white blood cells and your immune system resides in, and the cancer cells find a way to hitch a ride there, and it can grow there, and eventually it can spread to the bone. And that can result in a lot of symptoms, and this is how men used to be diagnosed with prostate cancer. You would get severe bone pain, you can get heavy bleeding in the urine, inability to urinate because the tumor is so big. It can cause blockage with the GI system because it can push on the rectum and you have difficulty with defecation. And sometimes it can spread to the spine and cause spinal cord compression, which is a life-threatening illness that requires emergent treatment. The cancer also has the ability to spread to other soft tissues in the body. It can go to the liver, the brain, the lungs, and when it does that, it can cause problems with those organs. And eventually the cancer sort of overwhelms the person. It just continues to grow, and the body just doesn't have the energy really to fight it anymore. Now, this is a very slow process, so it's a quite uncomfortable and a very unpleasant way to go out, so to speak. Thankfully, though, we have treatment for prostate cancer, and we have many treatments for prostate cancer. So I'm going to touch on all 5 of these, and we're going to dive into them in a little bit more depth in the slides to come. So the first management strategy, it's more of a management strategy, I should say, is something called active surveillance. So active surveillance is a program where we watch the patient very carefully with a combination of blood tests and PSA to make sure that if they have a cancer, specifically a low-risk cancer, so a cancer that's not likely to spread, and watch them to make sure it never progresses. The next type of treatment we have is something called focal therapies. So these are a collection of different types of treatments that are designed to target just a portion of the prostate where the tumor resides. Next, you have radiation treatment, which delivers ionizing radiation to the prostate and the cancer. And then you have surgery or surgical removal for the prostate. And finally, in very advanced cases or in cancers that have spread already and left the prostate, we use hormone therapy and chemotherapy to suppress and control things. Are these treatments based off of how severe or lethal the cancer is? And absolutely, and we're gonna dive into that a little bit. So before we get any further the treatment, I do have to give a quick disclosure. So when you talk about the treating prostate cancer, this is a highly individualized process, and there's no one size fits all. The goal of this is really to go over the general advantages and disadvantages. Each case is specific to the patient, their quality of life, their sort of family history, their belief systems, to really make a plan, a shared decision making with their doctor to decide what is the best treatment to do with understanding of all the facts. The first, it's really more of a management strategy we have, is something called active surveillance. So as I mentioned earlier, this is a program of watching that PSA blood test, make sure the levels don't go up, and repeating biopsies in certain intervals to make sure that a patient that has a low-risk cancer doesn't spread and become something more aggressive and something lethal. We know this works because there's been many good studies that have looked at patients over a long period of time. Mainly there's 3 studies that have looked at patients that have been put on this for a period of over 10 years. And I've highlighted 2 of these studies here. The first one you'll see on the screen here is the Cannery prostate cancer study. And what they did was they followed patients with low-risk cancers that either got radiation, surgical removal, or they just watched them with surveillance over a 10-year period, and what they found was the prostate cancer-related deaths was 0.1%, so extremely low, okay? Now, I do want to highlight that about 50% of patients did need some form of other treatment at some point, either because the cancer progressed or they no longer wanted to watch the cancer. On the graph here, this is a second study called the PROTECT trial. They did the same thing, and they looked at patients with low-risk cancers. They watched them, removed their prostates with surgery, or did radiation, and they followed them up to 17 years. And at 17 years, there was no difference in cancer-specific survival in these patients. So all in all, that really supports that active surveillance is a valid and in fact preferred strategy, especially in my practice, in patients that are diagnosed with low-risk cancers of the prostate. Next, we're going to talk about focal therapies. I'm not going to spend too much time on these, but you may hear these out as you do research, or you hear, you talk to friends and family members that might, ask you about these or bring these up. Basically, it's a collection of different technologies that are designed to apply energy to the tumor and just a portion of the prostate, hence the name focal therapy. So one of the forms of energy that's given is cryoablation. So they use liquid nitrogen and helium to freeze the tumor and the portion of the prostate. The second thing they use is a high-intensity ultrasound called HIFU to try to deliver these ultrasound waves to the prostate. And there's new technologies being studied, such as electroporation and other things where they just try to use different physical properties to deliver some sort of energy source to try to destroy the prostate and that tumor tissue. Many of these right now are still considered to be somewhat investigative and experimental. We don't have good long-term data for many of these. They're very attractive because the side effect profiles are very favorable. So when you don't deliver that much treatment, you don't get much in terms of side effects, and that's why it's very attractive for some patients. But it comes with the caveat that one, many of these treatments are different forms of energy, so are you really comparing apples to apples? It's hard to say. Number two, it really is dependent on how good is our technology at finding the tumor or tumors. So we're highly reliant on our MRI and our biopsies, but there's errors anywhere along that process. So sometimes if you don't find where the real cancer is, well, you're not treating the appropriate area. And in men with very aggressive cancers, or they have more than one area of cancer, this treatment strategy is not very effective. Next, we have radiation treatment. Radiation treatment is a tried and true treatment for prostate cancer. This is typically delivered by the radiation oncologist, which we work very closely with, and it takes advantage of using ionizing radiation and delivering it to the prostate and the cancer. It comes in two flavors. The first one is what we call brachytherapy, which is delivering radioactive seeds into the prostate. And the second one is external beam, which is probably the more common option, and that's delivering high-dose focused X-rays to the prostate and sometimes the lymph nodes. The general advantages of radiation are that it's not very invasive or not invasive at all, so it's very easy to do in that sense. Initially, there's not much in terms of side effects, and we're able to get to areas that either we can't remove with surgery or we've tried to remove with surgery, but we're unsuccessful. The disadvantage of using radiation is that it's radiation, so it can damage healthy tissue as well as cancerous tissue. And sometimes that can lead to secondary cancers that can develop. Uncommon, but can happen. It also leads to, like I said, damage of the other healthy tissue by the prostate, which can include the sphincter that helps you control urine. It can injure the rectum, and that can cause a lot of symptoms for patients. And unfortunately, after you've had a radiation treatment, these problems are not easily correctable with surgery. And the final thing with radiation is you get basically one shot at it. So after you've done radiation for prostate cancer, if there were any cancer to recur, it's very difficult to go back and do surgery to remove it because of all the tissue destruction and damage that we see from the radiation. Talking a little bit more about the seeds versus those high-dose X-rays. So the advantages of doing the seed therapy is it's a one-time treatment. You go under anesthesia, and we go through that perineal area, as I mentioned earlier, and they deliver those seeds directly into the prostate. Another advantage of it is it's able to deliver much higher doses of radiation to the prostate, and you get better cancer control within the prostate. Now this leads us to external beam radiation, which is high-dose X-rays, and like I said, the more common way that radiation is performed. The advantages of that are it's able to deliver radiation not just to your prostate, but also to the pelvis, so it can cover your lymph nodes, which is a place that cancer can spread to that you can't really treat with seed therapy. And because you're not giving such a high dose to the prostate, there's less chance that you can cause damage or injury to the urethra, which can cause many problems for patients down the road in terms of peeing and bleeding and things like that. And generally, as I mentioned, external beam is the more common option. It is a little time intensive up front. It's typically anywhere from 2 to 6 weeks, depending on the radiation doctor. And it's given, Monday through Friday, typically anywhere from 5 to 15 minutes. Where you go into the radiation center, you sit down, they shoot some x-rays, you go home, you come back the next day and repeat that process. And like I said, radiation is a great option for patients who are either unfit or unwilling to undergo surgery. And oftentimes they will add hormone therapy with it to get better cancer control. And I'll talk about hormone therapy here in the next couple slides. Next, we move into surgery, which is my world. So surgery involves removing the prostate and the seminal vesicles, the little structures attached to it. More often than not, we often will remove the lymph nodes as well to get a full understanding of the disease process. Traditionally, this has been done via an open approach, so one big incision below your belly button. Since 2005, we've had the development of the Da Vinci robotic system, and increasingly this surgery now is done with the Da Vinci robot, which has really revolutionized this surgery. Patients are able to recover much faster, much less blood loss, much less pain, and just much better patient outcomes in general. And it's done with 5 or 6 small incisions across the abdomen, and we put a camera inside and we do the surgery. Typically it's about 3 to 4 hours, and patients spend about a night in the hospital. And full recovery, meaning you're feeling pretty good, doing all your things that you did before surgery, is typically about 4 weeks. But patients feel pretty good once the catheter is removed after the surgery. So what are the benefits of the surgery? Well, the benefits of the surgery is the prostate is completely removed out of your body. The prostate, the cancer, the lymph nodes, they come out of you. We get a full understanding of the disease, so the pathologist looks at the whole thing. So we made your diagnosis based off of a small needle through the biopsy, but there could be something more serious hiding. We don't know. So once the prostate's removed, we're able to look at the entire thing and get a full understanding of exactly how aggressive is the cancer. The second thing is, and probably the biggest advantage of doing surgery, is that after you do surgery, if there were any cancer that were to come back, or if surgery could not remove all the cancer, you can always do radiation therapy afterwards to clean up the job. So one does not preclude or prevent you from getting the other. And this is a little bit of the third point is a little bit of a personal preference, but with surgery, you do all your healing up front. So things only get better with time. You're the worst you're gonna be right after the surgery, and things only get better, versus the radiation. A lot of times the damage that we see from radiation and such won't happen for 5 years, sometimes a decade or 2 decades later even. The disadvantage of surgery, so one, it's surgery, right? Nobody wants to get surgery if they don't have to get surgery. Second, men will experience a period of urinary leakage after the surgery. So the prostate helps keep men dry, and when that's removed, we have to use muscles that we've never used before to gain that control back. And there's typically a 3 to 6 month period where when men, if they stand up, they laugh, they do physical activity, they'll leak urine, and that degree varies. It could be as heavy and requiring multiple diapers a day, or it could just be a few drops that requires a liner. Permanent leakage, meaning leaking beyond a year from national data, is very uncommon. So that's about 5%. Most of my patients typically regain their continence control by about 3 months, sometimes around 6 months. But so that's not the norm, but certainly permanent leakage can happen and is one of the risks with surgery. The third thing is that surgery will affect the quality of your erections. And so the nerves that supply erections for men, they run on the bottom of the prostate. So anytime you do any sort of intervention that involves removing the prostate, you can damage permanently or temporarily those nerves, and that will lead to erectile dysfunction. Sometimes the cancer is so aggressive it involves the nerves, so the nerves have to be removed in terms of getting good cancer control, and that will inevitably lead to erectile dysfunction. Fortunately, there are many treatments that we have for it, but certainly if the patient's first and foremost goal is the preservation of erection, then surgery is often not the best option. And finally, without the prostate, the patient is not able to ejaculate anymore. Finally, we move on to hormonal and chemotherapy. So this is really the mainstay of this is giving androgen deprivation therapy, or compounds that reduce the body's testosterone level. Prostate cancer cells feed off of testosterone, and so when you withdraw the testosterone, they lose their food supply. They lose their ability to grow and divide and cause problems. This can be done in many different ways. There's pills by mouth, there's injections. Some patients get surgery to remove the testicles that make testosterone. And on top of that, there are other new medications that block the signaling pathways of testosterone. to better control things. Now, unfortunately, these do come with side effects, so the loss of the testosterone can lead to weak bone health, it can lead to hot flashes, fatigue, loss of libido, as well as put guys at higher risk for cardiovascular problems such as a heart attack or stroke. And so we have to use these medications very carefully. And finally, when we talk about chemotherapy, at least as it relates to prostate cancer, there's only really one kind that we give, and we give it in patients that have been diagnosed with very widespread cancer everywhere. We call that high volume disease. Those patients we know can benefit from chemotherapy. But unlike the other cancers that some of you may or may not be familiar with, chemotherapy is usually not a mainstay of treatment for prostate cancer. And very important that once the cancer has left the prostate, these treatments really are designed to delay months, often years, but are not designed to cure. Unlike with the surgery or the radiation approach that we talked about, those are more aimed for curing the patient. So I've given you a lot of information. So some of the take-homes to focus on today is that, number one, prostate cancer is quite common. 1 in 8 men will develop prostate cancer in the United States. Early detection or screening and checking for prostate cancer has significantly reduced that mortality by 50%. We do this screening and checking with a combination of a blood test and sometimes a finger exam. Between the age of 45 and 50, if you've not had a blood test for the PSA, you probably should. If you're 40 with those risk factors that I mentioned, you should be getting checked earlier. And like I said, the PSA test varies with age, but a cutoff of over 4 is never quite considered normal. It doesn't mean you have cancer, but it's not what we would say is normal. In patients that are diagnosed with low-risk cancers, active surveillance is the preferred strategy, meaning watching the PSA, doing biopsies here and there to make sure things don't progress. And radiation and surgery are the mainstays of patients for treatment for patients that need treatment if they have cancers that are aggressive but have not left the prostate, to answer the audience's earlier question. And hormone therapy and chemotherapy we use for very advanced and incurable cases. I will now get to the audience member's question. The question, I believe, was, are there any diets or any habitual modifications that a patient can do or undergo to reduce the risk of prostate cancer or prevent prostate cancer? In short, to answer the question very succinctly, is no. There's been many trials that have looked at different diets. They looked at vitamin D for a while, vitamin E, different things. So far, there's not been anything that has really been linked with a reduction in prostate cancer. I generally tell patients that, if it's good for your heart, it's good for your prostate. If we're talking about the surgery world, where I mentioned that the erectile function can be severely impacted right after surgery, it really depends on the recovery. So in many situations, we're able to do something called nerve sparing, where we try to save the nerves that supply the erections. If we're able to do that and the patient is young and has a good erectile function at baseline, many of these patients can get good erections with the assistance of using commonly used erectile dysfunction medications like Cialis, Viagra, things like that. In patients that either we can't do that nerve sparing operation on, or they don't have good erections to start with, there are other stronger medications that we can use in the form of injections. There's sometimes surgery where we can put in a penile prosthesis if those are in line with the couple's goals in terms of continued sexual activity. A TURP procedure is a procedure we do with a camera through the urethra and the penis designed to remove prostate tissue that's causing blockage and causing urinary symptoms. In short, it does nothing for the treatment of prostate cancer. It's really meant to alleviate the patient's symptoms in terms of urination. But often in men that are considering radiation treatment, if they have a very big prostate and we worry that they can't urinate after the radiation treatment, we often will do a TURP procedure either before or sometimes afterwards to reduce that risk of not being able to urinate after they've undergone radiation treatment. One of the common medications that's used for treating enlarged prostate called finasteride, okay? Men will also use it, it's also the component in Rogaine to help with hair loss. It blocks the hormonal process of the testosterone being converted to its active form. And what it does is exactly that. It shrinks the prostate and it can reduce the PSA by half. So anyone that is on that medication, whatever their PSA is, they need to double that number. So for that reason, as well as some other reasons, I really dislike giving that medication because the situation where you're getting these PSA checks often is with the primary doctor, and the primary doctor has a lot of stuff on their plates, and they don't always have the time or necessarily the concentration or perhaps the knowledge to understand that if a patient is on this medication, well, a PSA of 3, meaning 6, should warrant a visit to the urologist, and they wait. And because of that, that often leads to delays in diagnosis, resulting in more aggressive cancers at time of diagnosis. Our professional guidelines, if you look at the National Cancer and the NCCN, which compiles guidelines for almost every cancer you can think of, if you look at the prostate cancer guidelines, in patients that are diagnosed with intermediate risk, so middle of the risk cancers, the general recommendation is to do 4 to 6 months of the anti-hormone therapy in combination with the radiation. Now that timing is a little bit, it's sort of up to the provider, and sometimes logistics play into it. So typically, most people would like to see, probably about a month or 2 of that medication on board before starting that radiation treatment, but that's really a case-to-case basis. In patients that have high-risk cancers, the recommendation typically is anywhere from 12 to up to 18 months of that hormonal therapy. We have we have a collection of different parameters and variables that we look at to put a patient in one of these buckets. Some of that is PSA, it's the finger exam, it's how much cancer I find, what type of cancer I find, the Gleason score. And when you fall into a certain bucket, we recommend staging imaging or getting pictures, typically a PET scan, to look and see if there's any spread. And so for patients that have high-risk cancer, those patients, it's universally recommended that they undergo some sort of abdominal imaging to see if there's already some spread before we decide on whether or not the patient is a candidate for surgery or radiation versus starting them on hormone therapy or chemotherapy. The audience member's question was, if you find a positive lymph node, if you're doing surgery for prostate cancer and you're removing the lymph nodes and one of the lymph nodes looks suspicious or it's positive, do you finish with the surgery? Because of the fact that I said surgery is really meant to cure patients where the cancer is confined to the prostate. If it's spread beyond the prostate, is there still any role for taking it out? To answer that question, historically, the answer was always to abort. You don't finish the operation because the patient is incurable. We are now learning more and more that there are many cases where the patient can still be cured with removal of the lymph node if that's the only site of disease. So there is now a new category for patients that have spread, just to make things more complicated, called oligometastatic disease, meaning they only have 1 or possibly 2 or maybe 3 sites of cancer. And if you're able to get all those sites and you're confident you can get all those sites, well, for prostate cancer, for being such a slow developing cancer, there is a survival benefit for those patients. And now we're able to find spots of spread much better with the advent of better PET scans and things like that, which we would never have known about. We would have done surgery on these patients. We would never have had a clue that they had spread to their lymph nodes. And we would have just done it, and we would have waited for the final report, and it would have said, oh, the patient has spread beyond the prostate and the lymph node. We now know a lot of that information. And so it's becoming a very tricky world, but basically, depending on who you talk to, some people will say, yes, you should finish the surgery. Some people will say, no. I am of a belief that if you're confident there's only 1 or 2 sites of cancer and you think you can remove it all, I say you should do it. I think if the patient has no specific risks and their PSA testing is within limits, there's no contraindication that an older patient can't get testosterone. In fact, we now know that in many patients that have low testosterone, in male patients that have low testosterone, they actually can be at a higher risk for cardiovascular disease, heart attack, stroke, all the same risks that you can develop if I give you a medication to block your testosterone. And so in that situation, no. If I don't think there's any concern, if I check the PSA and family history and rectal exam and there's no concern in my mind that you have prostate cancer, I have no problem giving testosterone for those patients that need it. If you're on a blood thinner, that asks the question, is the heart healthy enough to handle it? And that depends on, what is going on with, the discussion you're having with your cardiologist. Now, patients nowadays are often on blood thinners because of atrial fibrillation. And if that's all you have and it's well controlled, then there's no problem with getting Viagra. But if you're on a blood thinner because you've had quadruple bypass, well, that might be a different story. Yes, proton beam therapy I group together with external beam. It's just a different way that the radiation is delivered. There's no difference in terms of survival. The only real advantage is it can save time, but proton therapy is very costly. So me being a little bit of a cynical person, that technology was really pushed by many places because it's a good moneymaker. but it's not a bad treatment by any means, but it's not superior compared to conventional external beam radiation by any means, except for the fact that it may save you time. You may have to do less treatments, but that comes at a financial cost for many patients. Well, thank you again for your time and attention. This has been wonderful.
To learn more about Sun Health Foundation initiatives, become a donor, or attend a future Coffee Connections event live, please visit us online at sunhealthfoundation.org or call 623-471-8500. Sun Health, empowering people to live longer, healthier, and more purposeful lives.